Kinoze n'ubukomagenda imbere y'ingabo yajyayo ngakarwana umushakamba w'imbaraga kabinja uhunga mu mburane za juru amuratira ingabo rutaraturwa rutarenda ruturitsa amuratira ingabo y'ibyuma twaramukanye ibyago wa mugabo we yese nyamiyi murwanire Malaria nurani urugamba rw'itanganya mama Wanenya Malaria nurani urugamba rw'abaza rugaragaza ibyo batabashaka bamiga kwingezo n'isamaza abandona iryo ni icumu ryacura gucungurwa n'iryo kijyambere berugitwaje uzaritwarana n'ingabo mugabo sinamenwe nayoborana n'itetera z'umukinzi mama we wanenya Malaria nurani ukagarama rw'amutagisha ubukombe bashimira imyato n'urugamba rw'abeza yagoye Wanetani wanetanga bawonero
kandi wachoka Imana
yagoye Malaza makuza rutabagera ndenya Malaria nurani rugamba rw'itanganyika yagoye
musazara dutahe yene musabe kingamba ngikanzonare yemwe nganzongariza u Rwanda nimeze yene mukabuze dutahe
Thank you so much, Inganzongari. If you've been to Rwanda or if it's your first time, you know very well that this is our special way to tell our guests that we are happy to have you here. Welcome all to this room. Welcome to the Convention Center. Ladies and gentlemen, good afternoon. Today, with the rest of the world, we are gathered here to raise awareness, inspire action, and celebrate the progress made in the fight against malaria on this Malaria Day, World Malaria Day 2024, under the theme Advancing Health Equity, Gender Equality, and Human Rights. My name is Vanessa Mupenzi, and I'll be your MC for this afternoon. For those who will need translation, the protocol team will help you to get the translation kits. Progress has been made, but a lot still needs to be done as long as we still have malaria death, a disease that twines research and public health. Ladies and gentlemen, allow me to welcome the co-chairs of the scientific committee who will deliver the opening remarks of this afternoon. Dr. Eric Demera, the Division Manager of the Research, Innovation and Data Science Division at Rwanda Biomedical Center, together with Professor Evelyn Ansa, who is the Director of the Center for Malaria Research at the University of Health and Allied Sciences in Ghana. Dr. Eric and Professor Evelyn, the floor is yours.
Permanent Secretary of the Ministry of Health, Director of the Global Malaria Program, WHO, Co-Chair for the MIM Society Secretary, Mrs. Joy, Africa CDC Representative, Professor Marcel, Chairs of Local Organizing Committee, ladies and gentlemen, distinguished guests, and dedicated advocates in a global fight against malaria. All protocol observed. Good afternoon. Bon après-midi. Muraho. In Kinyarwanda, it's Muraho. So a warm welcome again to the land of thousands of hills and thousands of solutions, and to the World Malaria Day. It's an honor and a privilege to stand before you as co-chair of the Scientific Committee of the 8th MIM Pan-African Conference on this momentous occasion where it has coincided with celebration of the World Malaria Day. Today, we come together to honor the progress, to reflect on challenges, and reaffirm our commitment to ending the devastating impact of malaria on communities around the world. Malaria remains a significant global health challenge, particularly in sub-Saharan Africa, which carries the high burden of more than 94% of cases and deaths. The World Malaria Day is a day to recognize the tireless efforts of healthcare workers, researchers, policymakers, and the communities who tirelessly strive to eliminate malaria and alleviate the suffering it causes. Today, we recognize that improvements in malaria treatments and prevention, which includes developments in effective malaria drugs, vector control, vaccination, expanding diagnostic tools, among others, have significantly reduced the burden of malaria. Furthermore, research and development has played a crucial role in malaria control and elimination efforts by driving innovations, improving existing interventions, and discovering new strategies to combat the disease.
Continuing from there, the theme for this World Malaria Day, accelerating the fight against malaria for a more equitable world, underscores the responsibility we have to harness the power of research and innovation to drive progress towards malaria elimination. To complement this theme and to set the tone for the next decade, the MIM Society set as its guiding theme, grassroots mobilization to end malaria, invest, innovate, integrate. Whether it is through the development of new diagnostics, the discovery of novel treatments, or the implementation of effective preventive strategies, each of us has a role to play in this collective effort. Indeed, there are critical roles for other sectors such as education, such as water and sanitation, such as roads and transport, and we all need to have our hands on the deck. While significant progress has been made in recent years, much work remains to be done. Malaria continues to exact a devastating toll on communities across our continent, particularly the most vulnerable population. Over the last 3 days of the conference, we have had the opportunity to engage in critical discussions, share groundbreaking research, forge partnerships that will shape the future of malaria prevention and control in Africa and beyond. I am confident, indeed we are confident, that these discussions and deliberations that have taken place over the course of this conference have yielded valuable insights to end malaria, highlighted areas for future investments, and provided innovative solutions as well as actionable recommendations that will inform and guide our efforts in the months and years ahead. We therefore invite us all here to seize this opportunity to renew our commitment to the ambitious goal of eliminating malaria from our countries and finally eradicating malaria from the world. Let us leverage our collective strengths, resources, and expertise to ensure that no one is left behind in our quest for a malaria-free world. Thank you again for your unwavering dedication and commitment to the fight against malaria. Thank you very much.
Thank you, co-chairs, for reminding us the need for continued efforts and collaboration to ensure that no one is left behind in the pursuit of a malaria-free world. Joining us next are program managers who coordinate malaria efforts from the field, bridging the gap between scientific research and public health action. This session will be chaired by Dr. Peter Olumese, who is in charge of malaria case management at the Global Malaria Program at the World Health Organization, and Dr. Ghislaine Ouedraogo, who is the program manager of the Entomological Surveillance Program at Pan-African Mosquito Control Association. Dr. Peter and Dr. Ghislaine, the floor is yours.
Good afternoon, everyone. And like we say in Nigeria, standing on existing protocol, we welcome you to this panel discussion. And we want to hear from the countries. We know that we still have well over 240 million cases of malaria, well over 600 deaths, most of it in sub-Saharan Africa. However, we also have some successes to celebrate. Some countries, Cape Verde, who will be with us, were certified malaria-free this year. So there is every reason to celebrate as we look at challenges and we look for solutions to those challenges. So with that, I would want to invite the countries, those in charge in the different countries to share with us today what are the challenges, what are the successes, and what are the plans going forward. I would start by calling, we have two high-burden countries, and we have a country that was high-burden, no longer high-burden, and of course, a country that has been certified malaria-free. And so join me to welcome to the panel the program manager from Uganda, Dr. Jimmy Opigo. From Burkina Faso, Dr. Christian Campore. And of course, our host, Dr. Amiebo. And lastly, from Cape Verde, Dr. Antonio. You want to say something? Okay. Okay, sorry. Okay, thank you very much. Today we are not going to have formal presentations. It's a panel discussion. And we would give you the opportunity to speak, but yet pose some certain questions to you that would allow us really look at all the various aspects in terms of what are successes, what are the challenges, what are the lessons learned, and indeed, what solutions and an opportunity again to reaffirm our commitment towards the goal that has been set in the global technical strategy. And you know, one thing I want to reiterate from the global technical strategy, which I think is very key, is that it says that it recognizes that all countries, irrespective of their current malaria burden, can take steps to accelerate efforts towards elimination. So it doesn't matter where you are, you can take steps to accelerate action towards malaria through an interactive process of analysis and implementation of intervention packages appropriately tailored to the sub-national context. And so with that, I want to call on our first panelist from Uganda, which is a high-burden country, and just to give us very quickly an update as to your progress and what challenges do you have, and how have you dealt with some of these challenges? So, Dr. Jimmy, over to you.
Thank you, Chair. Before I really go forward, I would like to appreciate all the scientists, the innovators. These last few days, we have seen a lot of work is going behind the scenes, and we can really imagine what responsibility we have to quickly take this forward and turn it into interventions and impact for the benefit of our people. We'd like also to quickly really appreciate I think the Rwandan people for having put an exceptional conference. Everything running seamlessly, and we really appreciate, and we are challenged. As you are aware, Uganda is one of the most high-burden countries, rated number 3, producing over 15 million malaria cases, close to 6,000 deaths as of the latest WHO report. We don't want to give any excuses for it. Our context is known by most people. We have perennial transmission all year round. We are not seasonal because we are just right on the equator. We have the aggressive falciparum, very versatile. We have Gambiansi, very surviving transmitting vector. But a lot of progress has been made. Actually, in the last 6-7 years, we have driven down prevalence from 42 to 9%, single digit, with so much work which has been. I would like to talk more of what we are going to do after here. I think from here I'm seeing the responsibility, especially the leadership required to quickly take forward what has come out of here. There's a lot in the horizon, in vector control, in managing the challenges we have in even artemisinin resistance. All the ideas are there. What is now required is to drive the change, the policy agenda, and quickly work on issues of implementation, but also work on how we can bring our communities along. Because what really challenges malaria most, as we know, is the efficacy, effectiveness gap. When you do these RCTs, you can measure a certain level of benefit which can be delivered. When the tire meets the tarmac, it's a completely different ball game. From the health workers in the way they're going to commit to delivering this, the way in which the people are going to behave, so major investment in the communities. And this we have seen very clearly in Rwanda here. We have seen that just switching from facility-based treatment to leveraging on communities. These are treating over 60% of the cases, meaning you treat in time before gametocytes are formed, before cases complicate, and then referral is perfect, and they have delivered. I listened to the malaria indicator survey yesterday. It's so humbling, getting less than 1%, and we are in the same ecosystem. We are in the same geographical zone. So I would like to take really no excuses, but only to see how we can go from here well energized and put in action. Thank you.
Really? Ok, merci beaucoup et merci d'associer le Burkina Faso à cette importante célébration. Et je voudrais justement dire un grand merci à l'ensemble des organisateurs et à travers eux au peuple frère du Rwanda pour nous avoir donc accueillis et acceptés sur ce plateau. Et pour revenir à la question, je voudrais dans un premier temps signifier toute la bonne progression que nous avions connue depuis justement la mise en œuvre du plan, donc de la stratégie mondiale de lutte contre le paludisme. Et depuis 2016, lorsque vous observez un peu la courbe chez nous, vous vous rendrez compte que de façon continue, elle est en baisse. Malheureusement, elle s'est montée un peu stagnante pour les 3 ou 4 dernières années et en évolution en dents de scie. Je veux parler donc de l'incidence. Mais on a vraiment un très grand espoir parce que l'année 2022, nous avions connu donc une baisse. Et l'année 2023, cette baisse s'est confirmée. Et on est véritablement heureux de dire que nous sommes donc passés en dessous de cette barre mythique que nous connaissions depuis un certain temps, des 500 cas par an. Mais je voudrais également signifier que tout cela, c'est vraiment à l'actif des interventions que nous avions pu mettre en œuvre de façon progressive. Je veux parler notamment de la CPS, la chimioprévention du paludisme saisonnier. Je veux parler de la distribution universelle donc, des MILDA. Et je veux parler aussi donc, de la TPIG, donc le traitement préventif intermittent chez la femme enceinte. Mais il faut aussi dire que de mieux en mieux, nos populations comprennent et accompagnent justement cette lutte contre le paludisme. Et les agents de santé à base communautaire qui sont recrutés et qui, dans les distances, dans les villages situés à plus de 5 km des formations sanitaires, font donc le dépistage et le traitement du paludisme. Et c'est vraiment une très forte opportunité que nous saisissons également pour davantage donc, améliorer la lutte. Et nous avons donc la grande chance d'avoir été également de ceux qui ont commencé la vaccination contre donc, le paludisme et qui a été introduit au Burkina Faso depuis donc, le 5 février. Merci.
Merci bien, Dr Compaoré. Avant de passer la parole à Dr Aimable, est-ce que je peux demander de l'assistance? Voilà, merci bien. Dr Aimable, over to you.
Good afternoon. Yeah, it's a pleasure having you all this afternoon so that we can share our experience. As you can see, my colleague started discussing about challenges, but also effort put in place. For Rwanda specific, we have almost the same story. Maybe starting 2011, Rwanda was approaching elimination with only 36 per thousand as incidents. But a few years after, we recorded an upsurge, reaching around 400 per thousand as incidents, 10 times higher, with estimated 5 million recorded nationwide. This was the highest peak ever. Then you had to sit and discuss to understand what's happening as a country. And using data, this is number one, using data for decision making, we tried to understand the challenges. And the first challenge was the mosquito resistance to insecticide. Using bed nets was no longer giving result, and also spraying. We had to adapt to that mosquito behavior change. And using data, we deployed effective interventions accordingly. We targeted areas in 12 districts that were contributing to 7% of the national burden. But also, we introduced new types of net, the G2 net, with the support from USAID, the Global Fund as well, to make sure that we have a PBO net and a G2 net. And this also contributes to a huge decrease in malaria. But prevention is one thing, but also treatment is very key. There has been a policy change in 2016. Before that, we had the community health workers only managing under 5, but you had to adopt to that surge and also include adult and free of charge treatment at all levels. Currently, we have around 6,000 community health workers across the country, and 30,000 of them are able to manage malaria, but also fever cases. These are the ones who are our hero because they try to absorb all malaria cases, and currently they are managing 60% of all cases, reducing severe cases and death as well. Political support was very high because showing data, everyone was convinced that we need to advocate for malaria program so that we can address this as a nation, not as malaria program only. Over the last 5 years or 6 years now, we were able to sustain those effective interventions, and up to now, we have recorded a decrease of around 90% in terms of incidence. Last year, 2023, the national incidence dropped up to 47 per 1,000 from 400 per 1,000 in 2016. For cases, I think it's the same story. Because we dropped from 5 million cases in 2016 to only 600,000 cases in 2023. What is good, but 600,000 is a lot for us. We need to push and make sure that we meet Cape Verde, our colleague, eliminating malaria very soon. Maybe the final note is around the role for community health workers and also local NGOs supporting local leaders, using data, but also mobilizing community so that they can prevent malaria and get access to treatment. Currently, community health workers have reduced severe cases from 18,000 in 2016 to only 1,300 last year. It's a decrease of around 91%. Because of the early treatment and management. And of course, at community level, they are called community doctors, what is a priority for them because they are volunteers, they're not paid for that, but this is a local solution to make it so that as a country, we find our own solution. Mortality due to malaria reduced as well, and so far we dropped from 600 cases in 2016 to 51 cases last year, representing 91% reduction. I think we still have a long way to go because having 51 people dying from malaria every year, it's a lot, while we have access to treatment free of charge at community level, at village level. I think this is what I can share with you. Challenges still exist because we need to move to elimination. Cross-border aspect is very key. We still see some hotspots, mainly in the cross-border zones, but also sustaining interventions that work is not easy because we are relying on external funding, though the government has played a key role in supporting the program, currently supporting areas in 3 districts out of 12, but other 9 are supported by the Global Fund and the PMI. We need to make sure that we sustain our interventions and introduce new solutions as we use indoor interventions. Mosquitoes tend to change their behavior, now biting outside. This is a big challenge, and we don't have a clear solution to address mosquito biting outside. Here now we are trying to introduce mosquito repellent, but also engaging community how to manage breeding site and using drones for live siding. These are new technology we are using. They may be inviting you for those who are able to join on Saturday, so you can visit our site, how we are using drones for supplemental interventions. Otherwise, those we had, they're working well, but they need more interventions. Thank you so much.
Ready?
So thank you so much. It's a big opportunity to be here. I'm so glad to share the experience of Cape Verde. So when we talk in Cape Verde, we are talking in a small country with 500,000 people resident in the country, where the level of education is almost 100%. It means that when we talk about malaria, people are very aware about the disease. What we did good in Cape Verde, what happened to achieve the elimination? Firstly, we are islands, and when we see the history of malaria in Cape Verde, we have 7 islands where there is no local cases since century of years ago. We still had important local case in Boa Vista, is a tourist island that grew up a lot in last years. And in this island, there were reported less cases in 2015. And in 2017, we had an outbreak of malaria case in Praia, the capital of the country. And after this, with the WHO support, the program was reviewed and the new strategic plan was elaborated. What we did good, in Cape Verde, all the single malaria case is treated. The treatment is in the hospital. The treatment is strictly hospitalar. It means that there is no medicine in private pharmacy, and everyone needs to stay in the hospital minimum 3 days to be treated. We have the health capacity to do it. Since the post-sanitary, that is possible to detect malaria. Everyone in Cape Verde, every population is almost 30 minutes for a health service. It means that they are accessibility and is very easy to test it for malaria. The vector control in the country. We are talking in a country where we have more or less 3 months of rainy season. And it means that during the May 9 month, all the work is done with larval control. It means that we know where we have the breeding site. This breeding site is monitored during all the years. Of course, there's always a challenge, a new breeding site, things that will happen, but we try to monitor this breeding site to be aware what we have. And in 2017, we established a national, in the National Institute of Public Health, a medical entomology lab who had developed this job in collaboration with all the health structure, health delegation. I mean, we have 9 islands, 22 municipalities, and in each of these municipalities we have a vector control team. The other thing, there's a lot in the country, the government invests a lot of money on the health. It means that malaria is not, all the health systems is integrated in the country. I mean, when we have, in each municipality, we have a health delegation who do everything to the health. It's not only malaria, it's HIV. I mean, we have the health, human resource working in it and is integrated in this health system. And the government pay all the human resource, pay all the medicines, pay all the infrastructures, everything that we need to detect, treat, and follow malaria. And in the last years, of course, to achieve this elimination, we established a lot of partnership with, of course, WHO, Rollback Malaria, who supported Cape Verde, Global Fund since 2010 started supporting Cape Verde, but also with the national entities, private and public, and other NGOs who develop activities for malaria. And in the last years, as I say, with the medical entomology lab in the country, we started to develop research. We had a collaboration with colleagues from London School, from Université Cheikh Anta Diop at Dakar, and also in Cape Verde, the universities in Cape Verde started doing research for malaria. It means a lot of things was done, we achieved the malaria elimination, but we're still having a lot of challenge. It means, as I say, being island countries now with climate change, with mosquitoes behavior changement, with the new vector that could be introduced in the country, there's a lot of challenge in the country to keep the robust entomological surveillance, but also the epidemiological surveillance to be capable to detect a single case that could arrive in the country. Just to say that in last years we had 37 imported cases of malaria in the country. It's not too much, but it's still being case. For the years this year we have already 6 imported cases. It means that the country will still having imported case malaria, and our system needs to be capable to detect early, to treat, and to follow up all these imported cases. Thank you so much.
Thank you so much. It's interesting to hear and see the different levels of activity and interventions in the different countries. I just want to pinpoint 2 things or 2 aspects I want you to talk about. One is country ownership and political commitment and multi-sectoral approach. How have these played a role in getting you to where you are? And indeed, look ahead of what are the plans of engaging and, as it were, today is World Malaria Day. The whole world is talking about malaria. So we're talking about political commitment. What role has that played, or you see it playing in going forward, as well as multi-sectoral engagement in the fight against malaria? So I don't know if you want to start in Uganda, or please, any of the panelists can tackle this.
Thank you again. Now, malaria cannot be defeated by us technical people alone. Political will is very important, first in the policy agenda. For example, to choose that the services will be free, or at the community level, or as you have heard from Cape Verde, that all people will be treated in a hospital and kept there for 3 days, needs a high level decision and forcible decision. Health workers, when you're ambulatory, cannot say you must stay here for 3 days. So a high level political commitment is required at the policy level. Also to provide the resources needed, especially in the context of now dwindling resources and so many new effective tools to uptake. A big political will is required. But most important, the voice, because human beings' participation in this, they will listen much better from the political leadership. Now, coming to multi-sectoral action, I think that is where we can leverage the most. Just take, for example, school-going children, where right now we know the parasite load is and where the reservoir is. They are in boarding schools. If we wish to intervene there, we need to use the school system. Agriculture, irrigation schemes, big plantations, okay, which has a captive community living in camps. Do they appreciate that this human resource needs to be protected from malaria and it is their responsibility? The private sector, they buy insurance packages. To what extent will the benefit package cover malaria, or they will cover other conditions? You need to engage this, but also corporate social responsibility. We have seen in other countries the mines, the banks doing a number of things to complement our actions. So multi-sectoral action is key. The cities, the city authorities, I've been here now for about 5 days. I think there's no breeding ground because me, I've not seen a mosquito since I have been here. Now, that is the work, that's the work of the city to keep it well fixed. Yeah. Yeah. This we cannot do ourselves. So I think I can even stop there. You can imagine what we can leverage if we work with multi-sectoral actors. Yeah. So like defeating malaria in urban areas is of the urban authorities, you know. Yeah, thank you.
Je voudrais commencer également par cet engagement. En fait, l'engagement au Burkina Faso, l'engagement donc jusqu'au plus au sommet donc de l'État burkinabé, nous l'avons. Nous avions tout récemment eu la déclaration de son Excellence, le capitaine Ibrahim Traoré, qui a invité l'ensemble de la population à faire de la lutte contre le paludisme une priorité. Donc nous avions donc cet engagement. Nous avions également cet engagement parce que, vous saviez, le programme national de lutte contre le paludisme a été érigé chez nous en secrétariat permanent pour l'élimination du paludisme. Et nous avons donc changé d'ancrage. En fait, le secrétariat permanent est maintenant directement rattaché au cabinet du ministre. Donc cet engagement, nous l'avons. Nous avons un engagement fort politique. Nous avions également même bénéficié, et lorsque donc justement nous avions introduit le vaccin contre le paludisme le 5 février 2024, et l'Assemblée nationale de transition a voté un budget pour appuyer justement l'extension de cette vaccination à l'ensemble de la population concernée, notamment de la cible. Donc cet engagement, nous l'avons donc au Burkina Faso et nous voulons donc aller de l'avant. Et chez nous, on dit il faut savoir aller vite et bien. Et c'est justement sur ça que nous sommes. Et pour l'engagement, donc également la participation des autres secteurs, il faut dire que nous travaillons également à nous l'avoir, parce qu'ils sont peut-être à certains moments pas toujours conscients de ce qu'ils font déjà comme action qui tente donc dans l'amélioration justement de la lutte contre le paludisme. Et nous voulons donc mettre cela en exergue et faire de telle sorte qu'ils prennent à bras le corps justement cette lutte qui doit donc être là. On a parlé tantôt donc des municipalités. Chez nous justement, on a eu malheureusement cet épisode que nous avons connu aussi avec la dengue. Et comme j'aime à le dire, on utilise aussi par moment la dengue pour frapper le palu. Et justement, de fait de pouvoir mobiliser davantage les gens pour aller justement vers cette lutte globale antivectorielle fait que l'assainissement chez nous devient aussi une priorité. Et justement, surtout dans nos grandes villes, nous avions justement une très grande action qui se veut vraiment devenir pérenne, et à chaque fois, on appellera les populations donc à cet assainissement. Donc, je pense que je peux m'arrêter là parce que justement mon collègue l'avait également dit. Merci beaucoup.
Thank you very much. Rwanda, I will modify the question a bit for you. So it's, you've told us, and we have seen that 10 years ago or 11 years ago, you were where you are now. Then cases went up, things went up. What are the lessons that you have learned, which also be of benefit to other countries? Of course, one, to show that malaria control going to elimination is not a sprint, it's a marathon. And if you remove your leg from the accelerator, you are almost back where you started. So what are the lessons that you've learned, and how are you putting those in place to ensure that we don't have a repeat of what happened previously?
And as you answer this, if I can pinpoint two key points. The health system strengthening approach, the multi-sectoral approach in Rwanda, particularly as it pertains to environment, housing, and urban and rural planning. And for Cap Vert, you mentioned research, academia, national. If you could shed light on that as well, as you enter this last mile of your elimination battle? Yeah.
Thank you so much. Starting maybe with a lesson learned, I think data use is very important because if you don't understand the problem, you can't find a solution. Deploying interventions, you need to know where to deploy them, but also to monitor if they are really giving impact. This is number one. Sustaining interventions that are working is also very key because spraying for 1 year, then dropping the following year, you are losing organs. And this has been seen in some districts already, where you could even delay for a few months, then you see a surge. I think we need to sustain those interventions. Third is about also community engagement and political engagement. I do agree that farmers need a net, but they need more than that. They need to know that mosquitoes are breeding in the water bodies. They need to control both early age of mosquitoes, but also adult mosquitoes. Currently, engaging local leaders and local NGOs, we try to train community members on how to detect mosquito breeding site. And if they're positive, they know how to do that. I do agree that having a net is very good, but some people may be misusing them, like fishing. This has been seen in some areas, but if we don't have local government on board, we may fail. We can reach the high coverage just 1 week after the campaign, but after 2 weeks, you no longer have a net at the community. This is another lesson learned. We need to bring local leaders on board. An effective insecticide is very key, but imagine if one is not opening the house for spraying. The coverage will be less than 90%, and you can't expect any impact because you are failing. I think these are key success stories you can suggest, but also recommend for other countries for use because if you don't use data, you are not sure that you are really approaching the elimination.
And for Capo Verde, you've been certified malaria-free. That's good. I keep repeating it because it's good to say, yes, you've been certified malaria-free. However, we know that's not an end in itself. So what strategies or what plans do you have? Or what changes did you need to make to ensure that there is no possibility of reintroduction? Because that's actually the end game. It's not just certification. So what are some of those things you have put in place to ensure that?
Thank you so much, Peter. As you say, you're right. In fact, achieve the certification, I can say it's not that is easy, it's not easy. But one thing is, when you have malaria case, you can test, treat, and follow up. The thing is, you don't have malaria now. How to prove that you don't have malaria is not easy, and we're still facing a lot of challenge. How the country try to put in place now? Firstly, you need to have financial support. The country needs to have money to sustain the certification. It means that activities need to be put in place. Entomological surveillance and epidemiological surveillance is the key. It means that at the national level, every health structure needs to have people thinking about malaria. We should not forget the disease. And we need to have tools to detect malaria. We need to keep it in the country. It's not, when we talk about islands, like small islands with 500,000 people, where there's no malaria for decades passed, we do not think in malaria. But the challenge now to the Minister of the Health is to still to do capacitation for these people to remember that malaria exists, and we need to be involved in it. Of course, we had challenge in the past. In example, we had some cases of Babes that came from US, and in the first moment when the lab technician did the identification, they classified it as malaria. What the country put in place now, we know that is not a WHO recommendation, but it's PCR to confirm all single malaria cases in the country. It means it's a lot of money, yes. It's expensive, yes. But we need to be sure that when we have a RDT, a microscopy test, that the technician in the lab says malaria, the PCR will confirm it's true or no. And the other thing, the question of at municipality empowerment. Who do malaria testing? Who treat malaria are at a community level? It means that these people need to have all these conditions. And what we have in Cape Verde, we have the municipal committee who work about all the healthy question. It's not only malaria, but as I said initially, is integrated. It means that this committee needed to be aware about disease and to work about it, especially in the question of vector control activities. We had the history of elimination in Cape Verde in the past for 2 moments. In 70 years, for 5 years, we didn't have local case. And the second moment in 80 years for 3 consequent years. But we have this lesson that after these 2 moments of it was not certified, but after these 2 moments, we taught to local case, we had increase of case. I think that the country learned a lot about it, and after this, one decision that was taken in the country is to decentralize all health, malaria activities to the health municipalities, and the other things now is how to put in place the policies regarding malaria prevention of reintroduction in the country. We have the new document elaborated with WHO support, and the idea now is to look how we can implement all the activities, interventions that are in this plan to, of course, to keep the country as malaria-free. Thank you.
For the 2 high-burden countries on our panel today, Burkina and Uganda, as we look to the next few years until 2030, and as you look internally at your national security and societal situation, how do you, in this last mile, integrate elimination around the reality of internally displaced people or cross-border reality?
Thank you again. Much as we are high burden, transmission is not even in the whole country because, you know, the topography and microenvironments, microclimate sets different conditions. Also urbanization, level of human development is not equal. Urban areas, for example, are unique. With good urban planning, you have the air light, good housing, automatically malaria comes down. Now, with data and stratification, and especially micro-stratification, you can deploy multiple appropriate contextualized implementation packages. And now WHO has allowed, since so many years ago, that you don't have to wait to reach that level to, like it is not sequential, you can concurrently be in control, in acceleration, in elimination. And this helps you even to test an elimination model for yourself. Like part of our country, which neighbors Rwanda, is a highland. It has always been below 1%, and elimination efforts had been attempted there earlier. Our challenge is when you have a pot of resources, and you know elimination efforts are very expensive because running after the last mile and it's very intensive. Do you apply it for transmission control, or you apply it to manage the clinical cases? This debate is a very strong debate which sometimes we lose out. Nevertheless, we know we have to keep demonstrating that the country is uneven, and all the different parts of the country deserve some action. If they are ahead, we clean them up, and then we shrink them up, and then clean outwards. In terms of cross-border action, actually last week, our Honorable Right Deputy Speaker made a very serious statement that his colleagues from this side said we are donating malaria this side. He said this is a very bad CV. We need to do something about it urgently. So cross-border action is becoming serious. Just even in susceptibility profiles, we have seen sometimes like the markers for resistance, this side are different, the one on our side are different. So we need one to share a lot of surveillance information. We need to synchronize interventions so that we limit cross-border switch of people to go and receive services the other side. The good thing, the East African region and even the IGAD region within different frameworks has put an arrangement for us to coordinate ourselves, like the Great Lakes Malaria Initiative, which was also born here with a big support from one of the sponsors, SFH, which has created an arrangement for us to keep talking to each other, and we have started sharing and synchronizing action. But a lot of work is needed because this is beyond technical people. It needs ownership at the political level, then it will facilitate our action at the technical level to cooperate. Otherwise, at our technical level, it's very easy, but needs to be clear at a higher level. And these countries here are very challenging and not exactly at the same level. Thank you.
Thank you.
Okay, thank you very much. I am trying to be the timekeeper. We can go on non-stop, but I think we should be bringing this to a close. And I would just want to give 1 minute each to the panelists to say something. What take-home message? Remembering one, this is a MIM conference, scientific, so what's the role of research? What sort of collaboration do you envisage to have both with country researchers, and what role is it playing? We did not talk about the biological challenges, resistance, and all of that in the course of this discussion, but those are there. If I give you 1 minute each, what take-home message do you want to leave or give to your neighboring country and those who are watching and others to take away from today? So if I start with, yes, Uganda.
So to the researchers, first, we appreciate. We have seen there's so much work which has been done, what is already ready for uptake and what is in the pipeline. Traditionally, we get in touch with you when it is phase 3 levels, but here we have seen even things which are still at the back end, either being repurposed or got. I think our responsibility now is to quickly drive the policy agenda, to uptake this, modify the financing, create the health systems to deliver it, and generally drive the change. I think that is the promise we can make to you, and that is the big lesson we have taken from here. That the challenges notwithstanding, the scientists, the funders, the innovators, industry is not sleeping. It is now us to turn it into impact. Thank you.
Yeah. Burkina?
Merci beaucoup. Non, je pense que pour ce qui est donc de la recherche, il faut dire que le secrétariat permanent, comme j'ai l'habitude donc de le leur dire, se nourrit véritablement des fruits de la recherche. Sans la recherche, on n'aura pas de quoi aller vers nos populations. Et cette recherche vient également nous éclairer sur ce que nous faisons donc sur le terrain et nous réorienter par rapport à ce qui doit être fait. Et nous voulons donc justement avancer. Et nous avions d'ailleurs, nous sommes donc dans cette dynamique, nous avançons véritablement main dans la main avec la recherche. Et justement, c'est la recherche d'ailleurs qui nous donne grand espoir pour pouvoir donc aller vers l'élimination donc du paludisme. Et je voudrais terminer justement par dire, puisque donc on n'a qu'une seule minute, que nous sommes véritablement la génération à qui il est donné de pouvoir éliminer le paludisme et nous devons donc nous devons de la saisir. Merci beaucoup.
Thank you for the floor. Maybe I have two key messages. One is around using data for resource mobilization, because we need more evidence, but local evidence, not external evidence. Local evidence to be used for resource mobilization if we need to sustain our interventions and move to elimination. Second is about program managers, my colleagues. Mosquitoes cross without visa, but people need visa. We should be also learning from mosquitoes and share data without visa so that we can learn from other countries. Thank you.
Thank you so much. I just want to say that malaria elimination in Africa is possible. We make it. And thank you. And you may just add that about the research, Cape Verde is a rich market. We are a small country. We have only 49 years of independence. The research is not yet are strong in the country. We need support. We need to develop partnership, focus on research to initially to evaluate what we did well, what worked well, what we need to improve to keep Cape Verde as malaria-free and to share this experience with the rest of Africa. Thank you so much.
Okay, I call on my co-chair to round up, and I would close.
Great, so this is very invigorating. We started this MIM conference with a call to action from Professor Leke, informing us that this Yaoundé Declaration cannot and will not be like the other declarations. It's not business as usual. And I think what we just heard here is that it's not going to be business as usual. We will use our national data. We will pivot to the light and the tune of the data that we have nationally. We will collaborate. We will engage the community as partners. We will amplify what we have in our toolbox, and we will utilize it in a very consistent and efficient way. So with that, I'd like to say thank you to our panelists. Thank you for the courage. Thank you for recognizing the role that each of us play in this last mile of the elimination battle as we approach 2030. And thank you for your remarks today.
Very participatory audience. Thank you.
Thank you so much to the NMCPs from various countries. As they well said it, a committed leadership, a multi-sectoral approach, data-driven interventions. Allow me to quote Dr. Christian, on doit se nourrir des résultats de la recherche, and also a community engagement, which is why I kindly request you to acknowledge the tireless efforts of the work of frontliners who are the backbone of our success stories. Following the insightful discussions, we are going to turn our focus to witnessing the impactful malaria control interventions in Rwanda. It's a short video. I hope you enjoy it and you take the message back home.
Dans notre pays, le paludisme, c'est la première endémie parasitaire, c'est la première cause d'hospitalisation et c'est la première cause de décès.
Abali sukulu wa muze na samdi dimanche don lo ina don na bande bako bako bol ba de baka muze ay na ila wande don na jahal dana na ne kon.
C'est les enfants qui payent les luttes, surtout les enfants de moins de 5 ans.
Awanya de dambeze e muze na bol ma ba lezi ma de bi wanya de ngini mo njo ma ba lezi ma ba lezi mo zo lezi ba wumbi.
Seasonal malaria chemo prevention, in short, SMC, is a malaria preventive intervention consisting of providing medicines to children during the period where the malaria transmission is the highest to prevent them from getting malaria.
L'OMS avait recommandé la CPS en 2012. En 2013, on avait commencé au Togo, dans une région, avec l'appui de l'UNICEF, dans un institut.
Ma responsabilité, c'est de sensibiliser les gens à mieux comprendre les produits qu'on donne aux enfants. Donc bon, je vois qu'après la CPS, Paris s'est amélioré. Auparavant, c'était tellement difficile.
Il y a cet engagement individuel et collectif là que nous suscitons pour que vraiment les objectifs d'élimination puissent être atteints. Donc c'est vraiment notre rêve.
Ten years ago, Rwanda grappled with a silent killer that plagued its communities, malaria. The disease not only posed a significant health threat, but also hindered medical professionals from addressing other pressing health concerns. Malaria wasn't just a disease, it was a burden that weighed heavily on the shoulders of healthcare providers, demanding attention, resources, and countless hours of tireless work to combat its relentless spread. Malaria wasn't just a health issue, it was a roadblock to progress. With hospitals overflowing and resources stretched thin, the fight against malaria seemed like an uphill battle. Urgent action was needed to turn the tide against malaria. By investing in research and innovation, Rwanda pioneered strategies and new technologies that targeted malaria-prone areas and ensured that essential services reached those in need through community health workers. In 2023, nearly 60% of all malaria cases in Rwanda were successfully diagnosed and treated outside of a conventional health facility, but through a program known as home-based management by community health workers at the village level. Today, Rwanda has a network of 60,000 community health workers working at the village level, around 300 households, providing services such as malaria diagnosis and treatment, freeing up health facilities to deal with other, more complicated conditions.
A malaria case management strategy known as home-based management and trained 60,000 community health workers to diagnose and treat malaria at the community level. And our latest report shows that nearly 2/3 of those malaria cases in Rwanda were diagnosed and treated at the community level. This has led to a 90% reduction in severe malaria cases and death over the past 7 years.
Rwanda has followed the path of implementing a variety of strategies to respond appropriately to malaria, including the Zero Malaria Starts With Me campaign, a symbol of Africa's commitment to end malaria within a generation.
We are implementing Zero Malaria Start With Me campaign at the national level. It's a Pan-African campaign, and it was launched in Rwanda in 2020. And it consists of increasing the awareness of the communities, but also engaging local leaders to ensure that malaria control is a business of everyone, and that's why I call it Zero Malaria Start With Me, so that everyone has a role to play. The government, the Ministry of Health, RBC, but also community members, so that we don't wait for the government to come and prevent malaria while it should be playing a role as well. Key interventions included in these campaigns include mainly mass distribution of bed net. We started this last year, but this week there is an ongoing campaign in southern province to ensure that the entire country is fully covered with the net. Then also targeting some districts with IRS to ensure that also those districts, including Huye and Gatsibo, but also focal IRS in Kigali, are fully sprayed and reduce malaria through that campaign.
Akarere ka Nyamagabe twagiye tugira malaria iri hejuru mu myaka 2 ishize, ariko ubu ngubu kubigaragara iyo mibare yagiye igabanuka kubera abafatanyabikorwa twavuga Minisante, RBC, Rici ndetse n'ingobyi bagiye badufasha mu buryo bwo kubona inzitiramibu tukabona n'imiti ku gihe.
Twatangiriye gufatira inzitiramubu si ubwa mbere tuzifashe, hashize igihe kirekire. Iyo twazibonye malaria iragabanuka.
As we commemorate World Malaria Day, let us renew our commitment to ensuring that every individual in every corner of the globe can live a life free from the burden of malaria. Zero malaria starts with each and every one of us.
The theme for this year that started like 4 years ago in Rwanda, it's Zero Malaria Starts With Me. As I mentioned when we started, this year we had the chance to celebrate the World Malaria Day with all of you because you came for the 8th Pan-African Malaria Conference. This conference has two co-chairs that I would like to invite as we transition into our next segment, Professor Claude Mambo Muvunyi and Professor Rose Leke, who are the co-chairs, and they're going to chair this next session, a panel discussion themed grassroots mobilization, investment, innovation, and integration for malaria response. Professor Claude and Professor Rose, the floor is yours.
Thank you very much, MC. Good evening to everyone. Good evening. Bonsoir. Are we still keeping the energy that we had the first day of the start of this conference? Yes. So again, thank you very much for being with us today as we celebrate World Malaria Day. I think we are going to welcome some high-level speakers and panelists, which I think they're going to really be with us, providing some solutions to the challenges, giving some promises that we recently heard from program managers. So I think we have the privilege to be with some high-level experts, head of regional international organizations, head of funding institutions, but also head of product manufacturing. So I think it is a very good opportunity for them to also be part of this effort for malaria free. And I want, first of all, to invite Dr. Raj Tajuddin, who is the acting Deputy Director General for Africa CDC. And we all know that Africa CDC is one of the health agency that was established by African Union in January 2016 to support public health initiatives of member states and also strengthen the capacity of the public health institutions to detect, prevent, control, respond quickly and effectively to disease threat. So the institution serves as a platform of member states to share and exchange knowledge and lessons among member states to address emerging and endemic diseases, including malaria. So Dr. Taj is going to discuss about how Africa CDC is also integrating integration with other non-African institutions to achieve a malaria-free Africa. Welcome, Dr. Teji.
Thank you, Professor Cloud, Professor Rose Leke, my teacher, my mentor. Always good to be with you. In 2022, when we had the CPHIA, I was privileged to be on a panel session which you chaired in this same room. So it's always good to be back. So, Excellencies, distinguished colleagues, ladies and gentlemen, I bring you greetings from the Africa CDC. First and foremost, let me share with you apology from my boss, Dr. Jean Kassea, who actually would have loved to be part of this discussion because when it comes to malaria, it's something that is really very close to his heart. He's currently in France, on another mission, trying to address meningitis as far as the ongoing outbreak in some of our member states are concerned. Now, having said that, let me start by thanking the organizers of this particular meeting, talking of the government of Rwanda, the Rwanda Biomedical Center, one of our national public health institutes, and of course, the multilateral initiative on malaria. So, what precisely is the Africa CDC approach to malaria? So, simply put, our approach has always been a system approach. Specifically, what is it that we are doing as Africa CDC really to support this malaria control agenda? So let me start with the community health systems. In 2017, our head of state and government met in Addis Ababa, Ethiopia, and they did issue a declaration calling on all member states, together with international partners, to support the agenda of recruiting and training 2 million community health workers, as a foundation for our primary health care system. Today, we are nowhere near that. And when DG Jen Kassea came on board, this became one of his flagship agenda. And what exactly does he want to do? He really wants to see us training and recruiting 500,000 community health workers between now and to 2027. And of course, we all heard the submission from a colleague from Rwanda, really articulating the role, the importance of community health workers. In fact, he says so many good things about community health workers. The only negative thing he mentioned is the fact that these 6,000 or these 60,000 people are working based on volunteer. We do not want to see that any longer. We want our community health workers to be salaried. And the Africa CDC, through the African Union, is pushing this agenda strongly. Number two, the issue of cross-border approach, to malaria vis-a-vis the community approach. So Africa CDC is really driving a very strong surveillance agenda. At the community level, we want to see a very strong community-based surveillance system, that will be able to support not just only malaria, but other infectious diseases. And by way of regional approach, we are also promoting what we call the regional integrated surveillance and lab network that will allow us to harness the different public health assets in the different regions to be able to respond to malaria and other equally important infectious diseases. Number 3, in February this year, our head of state and government met in Addis Ababa, Ethiopia, and launched what we call the platform for harmonization of African health product manufacturing. Again, this is aimed at ensuring that we do not just continue to import, vaccines, diagnosis, therapeutics, other medical products for 1.4 billion people on the continent of Africa, but begin to produce our own products locally. Let me, at this junction, give you one quote by President Paul Kagame, when he did mention that health security cannot be guaranteed through goodwill. So we really need to be very proactive as a continent. And one of what we're trying to do, and Africa CDC is taking charge of that, is to push for local manufacturing capacity for some of these health security commodities. And if you talk of malaria, we can imagine that most of our diagnosis kits are imported. Most of our insecticide treatment nets are imported. I'm sure there are colleagues from Global Fund in the room. If you ask Global Fund today, who are the major suppliers of these mosquito nets, you will be amazed that most of these mosquito nets are actually imported from outside of the continent. So really going forward, Africa CDC is taking the lead to ensure that we build our local manufacturing capacity so that we'll be able to produce locally. And to incentivize that, our head of state and government have also approved what we call the pool procurement mechanism, that will allow us to be able to put in place a digital platform that will allow us to be able to buy in bulk, thereby, driving down the price, and not only that, also encouraging local production of some of these health products. Let me shift here and talk a little bit about malaria vaccine. Today, we know that about 2 malaria vaccines have been approved, but how do we ensure that this vaccine gets to the people who need this vaccine the most? So currently, we're working with Gavi, to put in place a framework that will allow us to be able to ensure that there is equitable distribution of this vaccine. Not only that, to also make sure that these vaccines are actually affordable, or people are able to access this vaccine irrespective of the ability to pay. Number 4 is the issue of a partnership. Today, our head of state and government have called for a new public health order. This is a new public health order that is underpinned by 5 critical pillars. But allow me to unpack the 5th pillar, which is about respected action-oriented partnership. And I think there is no better way of describing respected action-oriented partnership than the kind of coordination and collaboration that has been put in place to really address this issue of malaria. So in this space, Africa CDC is working with a lot of partners, to see how do we make sure that in terms of efficient and effective allocation and distribution of resources, we're able to work with these partners so that there is no unnecessary duplication of effort. And we'll continue to work with Gavi, Global Fund, Afrexim Bank, UN agencies, WHO, UNICEF, and so on and so forth, so that collectively we are able to address this issue of malaria, in such a way that we are able to bring to bear in the comparative strength and the differential advantage of the different partners who are working in that particular space. So to conclude, as Africa CDC, we continue to emphasize on the importance of 1, integration. We do not want to continue to see vertical programs. Whatever that is coming, let's integrate in such a way that we strengthen our health system. Number 2, multi-sectoral coordination, critical. We need to ensure that all our sectors bring to bear in, their differential strength, their comparative advantages, talking of agriculture, talking of water resources, talking of health, all in the space of One Health, so that we use this particular effort to bring this malaria under control. Number 3, capacity building. Very, very important. We need to continue to ensure that at the PHC level, We have what we describe as best-in-class health workforce that is integrated, that is professionalized, and that is adequately salaried. Number 4, data and science, critical. And Africa CDC will continue to work with our member states to make sure that our policy, our practices are informed by science and data. And I think there is no better way of really moving this agenda forward rather than in the space of malaria control. Number 5 is the aspect of sustainable financing. We cannot continue to rely on partners from the global north to drive this agenda. So we need to continue to really put in effort to make sure that we mobilize resources domestically, to control malaria and to control other endemic diseases. And last but not the least is one of the unique selling points of Africa CDC, being a technical agency within an intergovernmental political institution. So talking of mobilizing the necessary political support. For some of you who have had the privilege of attending the AU Summit, you will know that one of the standing agenda for every AU Summit is the issue of malaria scorecard. And this is aimed at ensuring that there is adequate political support, adequate political mobilization, as far as malaria control agenda is concerned. So, colleagues, ladies and gentlemen, and partners in the room, Africa CDC stands ready to continue to work with you so that it's not only Cape Verde, that will eliminate malaria. So we want to see more and more member states, actually being in the same position as Cape Verde. So on that note, I thank you, and Chair, over to you.
Thank you very much, Dr. Tej, for really continuing to ensure that there is local manufacturing capacity and capability. There is also integrations, use of data, but also domestic financing available for malaria interventions. So I think then our next panelist is Dr. Daniel Ngamije, who is director of the WHO Global Malaria Program. And we all know that WHO Global Malaria Program is responsible for coordinating WHO global effort to control and eliminate malaria. The program is committed to supporting member states to achieve the global strategies targets through setting and dissemination of global guidance and policies on malaria, and also elimination, supporting countries as they adapt, adopt, and implement WHO global norms and standards for malaria control and eliminations. Please allow me to welcome Dr. Ngamije for his brief remarks. Thank you.
Thank you, Professor Claude. Dear Professor Rose, all members of MIM Secretariat, I'm really delighted to be with you in this panel. When I was thinking what I should communicate after this brilliant presentation from malaria program managers, I came to end saying I will be responding to 3 questions. The first question, do we really need to accelerate the elimination of malaria? If the answer is yes, how to do it? And the last, what can we expect as contribution from WHO? So regarding the first question, the why should we really eliminate malaria? I think it was recalled progress made so far since 2000, with so many lives saved, so many cases averted, and of course, it was mentioned that unfortunately, for the last 10 years or 7 years, the progress has stalled. And the progress has stalled to the point that we are off track regarding global technical strategy targets by 50% at least. And if the trend continues like this, we will be off track by 2030 around 80%, which means we will not reach global technical strategy as agreed by member states in 2015. So we need to accelerate our fight against malaria because the disease remains preventable, the disease remains curable, and unfortunately, it kills. There are some best practices which were shared, the one in Rwanda, but also in other countries, which means it's possible to achieve GTS targets. If Rwanda already in 2024 is doing so well, and other countries which were able even to eliminate the disease, like Cabo Verde, and we have in pipeline the dossier to certify elimination for other additional countries. It means it's possible to fight and win and control malaria. There are some threats that we know, a lot of biological threats. Resistance of parasites to most common use treatments, resistance of vectors to most used insecticide, new vectors arriving, and some gene deletion compromising the diagnostics. And we do have also other threats like climate change, increasing cases due to combination of different parameters. And we have also additional threats like urbanization. Most of our cities in most affected countries, we have huge and uncoordinated urbanization, bringing the risk of malaria, especially peri-urban malaria transmission, high. So we have a lot today in terms of threats to fix. But we have also opportunities. Among those opportunities is new vector control tools. These new tools, like new nets with dual active ingredient nets, they are there, very effective. From what was presented by Rwanda, part of, and of course in other countries, when they had upsurge of cases in 2016, 2017, part of intervention they implemented, it was introducing gradually dual active ingredient nets as solution, but also IRS, also by rotating different type of insecticide. We have also vaccines. 2 vaccines are now recommended by WHO, and as of now, they are implemented in 8 countries. And we have a list of more than 20 countries who submitted, who expressed the intention to have vaccine, and their dossier have been reviewed and approved by Gavi. It's a matter of plan to get vaccine and introduce. And there is a queue of additional 6 countries with their dossier under review. Means there are new tools which can help to fight and eliminate malaria. Now, the second question on the how. How to respond to that question, the response is so simple. It's really aligned with the theme of MIM, and thanks to organizers of MIM. The theme is grassroots mobilization to eliminate malaria, invest, innovate, and do what? And integrate. So if we want to accelerate elimination of malaria, 3 things. We need to invest. Invest in terms of additional resources to solve some driving factors behind the failure to reach GTS targets. Part of them, access to services. Access to services means you have people who are trained at community level, equipped with adequate tools to do diagnostics and to treat. It means you have adequate infrastructure in health centers. Means you need to reach the average that which is recommended by WHO, at least 1 hour walking distance. So if in a country you do still do 4 hours to reach the nearest health center, it means we need to invest in constructing additional health facilities to reach that minimum distance between people and the health center. Invest, it means invest in research. And that's why expert researchers, you are here. Invest in labs, invest in retaining highly skilled researchers and innovators, and make sure that what they invent, what they discover is really published, and you give the full support for them to go up to the end of the whole process. Invest means, again, the entire health system, because malaria should be integrated among other programs. We are saying invest, innovate. In terms of innovation, innovate in partnership. Partnership with the private sector, partnership with public sector, of course, the civil society, academics, and others. I want to insist on the private sector. Private sector, these are the ones who can invest in local production, recommended by our colleague from Africa CDC. If we want this health product to be available and avoid what happened at the time of COVID, where we had stock out of basic product due to transportation crisis. And when it was solved, the cost was extremely high. Local production should be something to be assessed and to attract private sector in the country where they can co-invest with foreign partners and therefore bring products where they are needed. And of course, innovate in the way we implement programs. There are still some countries where treatment of malaria at the community level is not yet implemented. Why? Because it's already proven as a very realistic, cost-effective, inclusive intervention. I think there is a need to bring that intervention also at the community level. It's a matter of innovate the way the structure of the system or the health system in a country is described. Last, we need to ensure that you have support from different partners. And this is where my last question, and I'm answering on it. What will be the role of WHO in assuring that countries are able to invest, innovate, and integrate their services? WHO, as you know, one of the main functions of it is related in defining norms and standards. I want to assure you that we, as Global Malaria Program, we are ready to provide all required support to ensure that norms and standards are quickly elaborated, validated by competent expert bodies, disseminated to countries, and we make sure that we give the whole support for countries to adapt and to adopt and adapt those norms. And it's really part of our strategic plan that we released, available on social media and on different platforms that we do have. You will see that the second pillar of our strategic plan is to promote innovation and research. We believe in research. 30 years ago, no one could say here that there is a vaccine. It was just some researchers somewhere in labs working hardly to get these vaccines. They are now there. It's no longer a dream, it's a reality with 2 vaccines and others to come, probably more and more effective vaccines, depending the mechanism that they will be using. The point is that we promote innovation and research. And of course, the third pillar is strategic information for impact. As mentioned by Emab from Rwanda, you use information to be first convinced yourself and to convince others in more resources, in more in their involvement for implementing activities. So that pillar within our department is the one interacting with countries to build their capacity in what we call subnational tailoring of interventions, to ensure that interventions are really customized on the context on the epidemiological, entomological data, and other parameters to ensure that the response is really tolerant to the reality of the local environment. And of course, we bring that capacity building in collaboration with different levels of the organization, the regional office and the country office, and of course, other partners with whom we collaborate. And the last pillar, it's about the leadership. The leadership is key in all these things, political leadership. Recently, we had in Cameroon a conference of ministers of health from most affected countries by malaria, the 12 most affected countries. Ministers of health, they sign a declaration. In the declaration, it's for more resources to be translated in more actions. Part of it, there is a component related to the research. They promise to promote research in their country. So colleagues from all these most affected countries, you are aware that your ministers committed to provide more support for research. So I want to congratulate all these countries who signed to the declaration and who decided to implement the content of the declaration. So we as WHO, we want to ensure that with a new process of being aligned, aligning the normative function and the pre-qualification function, we support manufacturers of products to meet criteria that are required in terms of safety, in terms of effectiveness, in terms of quality, but also in terms of what is required by all these experts doing systematic reviews of products to ensure that products are really effective and are meeting all required WHO standards. We want something which is predictable, which comes with accountability. As soon as a dossier will be submitted, meeting all these requirements, we will be having 12 months to release both pre-qualification if criteria are met, and of course, recommendation for use if all requirements are also met. This is an important reform in WHO, and this is to promote timely introduction of new tools to serve for different diseases, including malaria, for which a lot of people are suffering. So I want to end by these remarks saying that we need to accelerate the elimination of malaria. We know how to do it. It's about investing resources, it's about innovating, it's about integrating services, and it's possible to reach what you want to reach in terms of reducing drastically and reach GTS target by 2030, reduction of 90% of the burden compared to what used to be in 2016. I thank you.
Thank you very much, Director, for a call for the GTS implementation, a call to continue to implement the Yaoundé Declaration. But again, also, thanks for really continuing to make available norms, guidelines, adapt them, but also simplifying the pre-qualification within WHO. But again, you mentioned about investment. Investment is very important. And before investing, we need probably to have those innovations and also integrating. But again, for the invention, to invest, we are going now to move on to our next panelist, who is Dr. Anna Bodipo Mbuyamba, who is the Health Professor Director at USAID PMI, who is going to really tell us about what PMI is doing in many countries. And now they have a presence in 24 countries where they are contributing to the delivery of malaria interventions alongside Catholic technical and also operational assistance to equip and empower partners country to end malaria. And then she's going to really tell us and discuss further how partnership and collaboration with malaria affected countries will be further explains. Thank you very much, and then welcome to Dr. Han.
Good evening. Again, my name is Anna Bodipo Mbuyamba. I was given the name of doctor. Actually, I'm not a doctor, but thank you. I'm here representing the President's Malaria Initiative, the U.S. President's Malaria Initiative, on behalf of Dr. David Walton, who is the head of our program. Unfortunately, he was not able to come to this event, but sends his greetings and encouragement for all the work that's being done here and for our future engagements. PMI is an interagency initiative led by the U.S. Agency for International Development, USAID, and co-implemented with the U.S. Department of Health and Human Services Centers for Disease Control and Prevention, CDC. PMI was launched in 2005 by President George W. Bush to reduce malaria by 50% in 15 high-burden countries in sub-Saharan Africa by implementing highly effective malaria prevention and treatment measures. To date, this has been expanded to now actually 30 countries, with 27 partner countries in sub-Saharan Africa and 3 programs in the greater Mekong region. PMI's approach is to support proven, cost-effective interventions. The initiative prioritizes partner country leadership and working closely with the national malaria control programs. Investments are strategically aligned with country malaria control plans, designed to strengthen local capacity and health systems to maximize impact and ensure sustainability, while also delivering life-saving commodities. In 2023, PMI benefited more than 700 million people in 27 countries. Globally, in FY 2023, PMI delivered 36.8 million mosquito nets to protect 73.6 million people, supported insecticide spraying in 4.2 million homes, protecting over 15.5 million people, procured and delivered about 102.7 million rapid tests, and protected over 63.3 million people with malaria medicines. This was all done in collaboration with many of the countries here that were represented. Based on PMI's strategic plan in 2021 to 2026, the focus is to ensure that we partner with countries and communities for them to lead, implement, and also fund malaria programs. And as we are hearing today, the importance of our community engagement will only lead us to success into the future towards elimination. In PMI-supported countries, we work with local authorities through our local governments and implementing partners to ensure that communities are involved in decision-making, implementation, and ownership of malaria programs. For example, in many countries here represented, communities are involved in the micro-planning of net campaigns, planning and implementation of indoor residual spraying, and supervising frontline workers. In Nigeria, communities have historically relied on information from mosquitoes, malaria parasites, and malaria transmission from governments or aid groups. But now, for the first time, the community members, such as health workers, are taking charge of understanding and teaching others about the complex mosquito population in their communities, how to control them, and ways to protect themselves. The community collectors were trained to conduct community-based etymological monitoring in the Das local government area of Bachichi State, Nigeria, for PMI Evolve. This is part of the groundbreaking pilot that the PMI Evolve launched in October 23 to enhance sustainability by shifting away from periodic mosquito sampling conducted by visiting experts and instead relying on local collections by community members in the places where they live. Nigeria's ambitious community-based malaria collection pilot demonstrates the power of decentralized processes to drive local action. And when community members are in the lead, communities are empowered and better understand the disease, and eliminating malaria finally seems within reach. PMI also emphasizes investing in people and partners close to those who serve, those that we serve, Across all of our country partners, PMI works to strengthen local organizations to take a lead in the development and implementation of local action plans. People in the countries where PMI works know best the challenges they face and how to overcome them. Looking ahead, PMI is committed to shifting the leadership, decision-making, and implementation to local partners to enable each country to progressively take on more of the planning and implementation of malaria programs to fit their needs. When we talk about innovation, a question is raised: what is PMI working on to bring about to the table of countries about malaria elimination, especially in the African region? And what we want to say is that PMI is committed to ensuring that countries leverage new tools and optimize existing tools in the fight against malaria. We recognize that new tools are needed to address issues of resistance to insecticides and in our recent past, emerging resistance to antimalarials. In many of our PMI countries that we support, we are providing technical and financial support to countries to plan and mitigate these challenges. PMI wants to continue to work with partners in the research and development space to ensure that there are newer and more effective interventions in the malaria toolbox to reduce malaria cases and death. PMI also is committed to working with our partners to influence the support of innovation to develop new proven products and tools, and to also introduce them to countries that ensure their scale-up. For example, PMI has been supporting the introduction of the 2 recently WHO-approved malaria vaccines as part of reducing life-threatening severe disease and deaths. And what are the key lessons that we've learned at PMI over the last 15 years? And what are some of the best practices that we think we should be able to support going forward? Again, it's really working closely with the countries, national malaria control programs, in support of their national malaria control strategies and strong partnerships is imperative. As we heard earlier, evidence and database interventions are important in the control of malaria, that each country is unique, and as such, PMI wants to work to support their national malaria strategies for impact. In Rwanda, for example, we have seen that sustained indoor residual spraying combined with distribution of bed nets has proven to be very effective and even cost efficient because resources distribution is focused based on data informing us where it's most impactful. Another important aspect of our work is community involvement in all interventions. As informed, active, and engaged community is a tremendously important element for success of such interventions. And finally, we must also recognize that communities, the environment, the vector, and the parasite are continuously changing, and therefore our approaches must continuously change with them. That means being open to innovative approaches and partnering where it makes sense with other stakeholders with complementary sets of expertise. I thank you all for allowing us to be a part of this important work of the malaria control programs and elimination. And I think that PMI will continue to support where we can the efforts of national malaria control programs and governments here that are represented. And we thank you for your continued collaboration.
Thank you very much, Anna, for the continued technical and financial support to countries in the fight against malaria. So our next speaker is Mr. Kedar Gumest, who is the Deputy Director, Strategy in Malaria and Institute for Disease Modeling at Bill Melinda Gates Foundation, who is going to really explain how the foundation is supporting the grassroots and also locally driven initiatives in the fight against malaria, and how does collaboration contribute to the broader goal for malaria elimination. So welcome, Kedar.
Thank you, Professor Claude. Thank you, Professor Rose. Good evening, all. Dr. Philip Welkoff, Director of Malaria, sends his regrets. He joined MIM earlier this week, and he had some pre-existing commitments today. First off, I just want to say this has been such an invigorating conference. Thank you to all the organizers and presenters. I know it takes a lot of work, not just in the lead up, but all the research and analysis that has been shared here. It's been years in the making. So thank you, everyone. I'm honored to represent the Gates Foundation here today on World Malaria Day. Most importantly, though, I'm honored to represent our partners who are doing the hard work in the fight against malaria. It's important to reflect on how far we've come, but also on how far we still have to go to eradicate malaria. We are not on track with the global technical strategy, and there's quite a bit of work ahead to catch up. The Foundation remains committed to eradication in the 2030s, but there's no doubt we are far from it. Over the next 5 years, we need to make a big push forward at all levels, global, regional, national, and especially local, to credibly be ready for eradication in the 2030s. This will require innovations, such as genetically modified mosquitoes and next-generation vaccines that provide long-lasting and durable protection for all ages. The Foundation invests in R&D, but not only do we invest in science and product development, but we also invest in the community engagement needed around these products. These products must be developed with the input and understanding of communities. They will be the ones who will be using them on the front lines to fight malaria. It's also worth noting that climate change looms large. We will need to listen to communities and the grassroots to adapt and innovate as human migration, transmission dynamics change, and invasive Anopheles stevensii spreads. Getting back to the 5-year push forward, we're working with Rollback Malaria, who's leading this effort. This effort will bring together key stakeholders, including civil society and local champions. Focusing on the here and now, though, the Foundation is actively investing in the grassroots. We are excited to share that we're partnering with Rotary and World Vision to invest $30 million in Nigeria, DRC, Mozambique, and Zambia to enable community health workers, often women volunteers, with malaria training and commodities. They will also educate their communities on how to protect themselves against malaria. The Foundation is also partnering with JC Flowers to mobilize faith leaders so that malaria remains high on the local and national agendas. We are also looking forward to the next generation. With ALMA, we are mobilizing youth champions who are promoting bednet usage and advocating for resources. ALMA has already cultivated champions in 40 countries. We are also investing in training the next generation of malaria professionals in partnership with Makere, Strathmore, Pretoria, and others. It's also important to note the next generation is digital. Many of us are too. We're investing in digital media like Zero Malaria Starts With Me that activates athletes, celebrities, and government leaders to spread the word. These campaigns are active now in 23 countries, including in Rwanda, as we earlier saw. Finally, a key role for the grassroots is community accountability to ensure that interventions are reaching those who need them, and the interventions are working, especially in the face of spreading insecticide and drug resistance. We're working with civil society for malaria elimination to ensure that community voices are elevated in the decision-making around malaria control. On the global stage, the Foundation also has a platform called Goalkeepers, which we use to elevate the voices of local leaders, often youth leaders, at the UN General Assembly. The focus here is on maintaining progress against the Sustainable Development Goals. Ultimately, though, to close, we are only going to eradicate malaria because of the heroism and courage of communities and grassroots leaders. They are the ones who will sacrifice and go the extra mile in the hardest places as we approach eradication. We owe it to them to listen to their needs, fully involve them in decision-making, and equip them with the tools needed to eradicate malaria. Thank you.
Thank you, Kedar, for the foundation investment into partnership, development of new tools, research, but also focusing on system changes that can be adaptable to the new challenges that we are facing. So our last but not least speakers is Mrs. Sylvia, who is the interim CEO at MMV. She's going to discuss with us their new strategies around product development and also that focus on really curing patients, preventing infections, but also eliminating malaria. We focus on equitable partnership as one of their cutting priorities. Welcome, Ms. Sylvia.
Thank you, Professor Claude and Professor Rose, for inviting MMV to this panel. Hello, everyone. After listening to your presentations for 4 days, I can say you are a truly inspiring crowd. When people ask me back home what I do for work, I tell them I work in malaria and I work for MMV, and we help develop drugs for malaria. So they say, how does this work exactly? You are based in Geneva, you don't have any labs, you don't have a facility, you don't have a manufacturing plant, so what do you have? I said, that's true, we have none of that, but we have partners. In fact, we have more than 500 partners around the world, and many of them in sub-Saharan Africa. So perhaps let me spend 1 minute to explain our business model. We are a product development partnership, which is short for a public-private partnership that does product development. We raise funds from philanthropy, from the public and the private sector, and we use our malaria expertise to support specific projects in discovery, development, and access activities. And it has worked quite well. We have been in existence for 25 years, and we have brought forward 15 new anti-malarians, and we have saved an estimated 15 million lives. As Professor Claude mentioned, we have launched a new strategy, our 24-2030 strategy. We are remaining true to our mission, which is to cure malaria, prevent malaria, and eliminate malaria. But we also have what we call cross-cutting priorities, and those should permeate all the things we do. One of them is equitable partnership. We want to ensure that everything we do is done in an equitable way. Now, what does that mean, equitable partnership? That means that there is co-leadership with our partners. It means there is shared decision-making, and it means that the activities we undertake are determined, in fact, dictated by the needs of malaria endemic countries and the challenges that are faced by community health workers. So perhaps the best way to illustrate that is to give you a few examples. We are right now developing a document for new TPPs, target product profiles. And this document is being prepared and co-created with malaria endemic countries. So together we determine where we want to go and decide on a new target profile, which is going to dictate the whole development pathway. When our partners, such as Novartis or Merck or Zydus, start developing non-ACTs, non-artemisinin-based combinations, anticipating the rise of resistance. When GSK develops a single-dose treatment for the relapsing form of PVIVAX malaria, when Fosun comes up with a new treatment for severe malaria, a new formulation which is much easier to use, it's a new injectable artesunate. When they do all that, they listen to the needs of malaria endemic countries. When we sit down with a manufacturer in Africa, in this case UCL in Kenya, and when we help them get WHO pre-qualification for their anti-malarials, we are empowering them. We are doing the same thing with manufacturers in Nigeria, and we'll do it in other countries as well. When we sit down with communities to design the packaging on an anti-malarial, when we look at the pictograms, when we ask them whether they are easily understood and whether they are culturally appropriate, we listen to what they are saying. They are, in fact, the decision makers. They tell us, no, that's not the way you represent things. You need to use another design. They are part of the decision. I'll give you a final example, which is a phase 1 study that we did. Usually when we conduct our phase 2 and phase 3 studies, we do them in malaria endemic countries, obviously, and many of them in sub-Saharan Africa. But when we do phase 1 studies, we usually go to the UK or to Switzerland. This time we decided that it was time to do a phase 1 study in Africa, and we selected a site in Tanzania, in Bagamoyo, that's the Ifakara Health Institute, and we did our phase 1 study there. What was unique about this collaboration is that the study design was co-created by Ifakara and by MMV. The protocol was written by MMV and by Dr. Florence Milando in Bagamoyo. And the result was a tremendous success. There had been a lot of sensitization in the community to explain why we were doing this study. It was a food effect study. Why we were doing it, why it was important for people to participate in the study, because they would be the future beneficiaries of this product. And it worked. Magically, when volunteers started coming in for the study, there was an equal number of men and women, which is what we wanted. There was no loss to follow-up. Everybody came back for follow-up visits. And we are now collectively or collaboratively analyzing the data. So this was a true example of an equitable partnership. The beauty of an equitable partnership is that when it is truly equitable, when the processes are inclusive, the end products, the products that are going to be generated by these collaborations, are going to be reducing inequities. I will leave you with that thought, and thank you for your attention. Thank you.
Thank you very much, Sylvie, for focusing on equitable partnership, and also for really thinking also relocating most of your clinical trials in Africa, where the problem most of the case. So now I'm going to pass over to my co-chair, Prof. Leke, to moderate the rest of the session. So thank you very much again.
Hello. Yeah, it's working. Thank you. Thank you very much, Co-Chair, Prof. Claude. And I just want to thank all the speakers. You know, that was so enlightening to see what's happening to all these institutions and what's happening on the ground we've heard. And the one thing, we don't have time. I wish we had time. We'll have a 1-hour good discussion. But I'd just like to ask you, all of you, just to let us, we heard the National Malaria Control Program, you know, officers here, they told us about what's happening there, the challenges they have, and how they're moving on. Is that something you think they should be doing that they're not doing? Or is there something they're doing that they should not be doing? I mean, what hit you in what came out from them? Just that, you know, let's not get in. We don't have much time to get into much discussion, but I'd just like to hear each one of you at least to tell us that. For Africa CDC, I had a question. How do you communicate on the ground? Because you don't have offices everywhere. It was so interesting, engaging with countries, and how do you engage with them? I also was interested in that. So can I hear you start, and then the others will continue. Thank you.
Thank you, Prof. So let me start with your second question, then I'll go back to the first one.
Yeah.
So the Africa CDC operating model is, we have the headquarters in Addis Ababa, and in each of the 5 geopolitical regions, we have the regional coordinating centers. We have Abuja, we have Cairo, we have Lusaka, we have Nairobi, and we have Libreville. Now, in each of the member states, we have what we call the National Public Health Institutes, you know, that we work closely with. In fact, they are our entry points to the member states. So, for instance, in Rwanda, I work closely with Cloud because he heads the Rwanda Biomedical Center, which is the National Public Health Institute of Rwanda. So this is the way we establish our presence as far as member states are concerned. Now, going back to your first question, I think listening to all the presenters, you will see that perhaps what is lacking is that platform that allow best practices and experience to be shared between member states. Listening to Cape Verde, you see that they've come a long way in terms of putting in place what it takes for them to be able to eliminate malaria. We have also seen that Rwanda is not far, you know, behind Cape Verde. So really, there's so much to learn from one another. So I think as a regional institution, what perhaps we need to do more is to create a platform that allow best practices to be shared. Because when you replicate an agenda or a project in a representative setting, you know, it allows you to be able to achieve some of these things that we think are not achievable. So let me stop there because of time.
Thank you. Thank you very much. Yes, let's hear from you.
Thank you.
Everybody brief. You know,
yes, I will be very brief. And I will respond as a former National Malaria Control Program manager. It's like 20 years ago? Something like that. So I think what they don't do, they should be doing, not because they don't want to do that, just because they need, there are some prerequisites. It's about data use. I believe they can do more if they are capacitated with required infrastructure to collect data, to analyze data, and to take decisions based on information generated by data analysis. This is one thing. It requires means they don't necessarily have because it should be part of what we said, investment, global investment in the health sector. At least they can convey the message to their leaders. The second thing they are not also doing, or sometimes they should be doing if required, it's about integration. We do still have old version of institutional arrangement in some countries where we have very strong vertical malaria programs operating in silos, in an isolated manner. We were there, at least in this country. We are no longer there because malaria is integrated, part of communicable disease and non-communicable disease department here in Rwanda. The RBC, the Rwanda Biomedical Center, It's a long story for moving from vertical programs, HIV, TB, malaria, and others, in one department having non-communicable disease and communicable disease with one head of department and some shared function in planning, budgeting, and using of resources. You have a lot to save as we are suffering for resource constraints.
Thank you very much. Yes, just very briefly, I'm coming, give us a few minutes. We started very late, so give us a chance, please. Yes.
I think I will just re-emphasize what I think Dr. Amable and others had said about the importance, again, of data sharing. This is a meeting, this is an event where we have an opportunity to learn from the positive things that are happening in all the countries that are here represented, and that we break this barrier of keeping information to ourselves or thinking that our programming is unique in the sense that there's no other way in which we can learn from others. And I think we've seen here, we've learned here, and that we have continued environments where we can have this type of exchange for the betterment of malaria control program and eradication.
Thank you. Yes.
It's easy for me to be brief because I think my earlier panelists touched on very similar topics. So I think the one point I would make is echoing Daniel and Anna in terms of use of data to some nationally tailored interventions. I know country programs are doing this. I think we can do more. I think that it can be enabled by sharing data more freely. One of the things I was struck by this conference was yes, we're in a difficult spot in terms of the global technical strategy, but there's a lot of reasons to be optimistic. There's a lot of innovation. And down the line, the toolbox is going to get more and more complicated. And the use of data will drive the decision-making of the right tool in the right place at the right time. And we need to continue to build that muscle.
Brief as well. I believe in the power of training. So I think one thing they could do is train. Train community health workers, train people who are at the front line, because sometimes you don't need much to adjust an intervention. If you clearly explain that an ACT needs to be taken for 3 days, then the mothers will not be tempted to keep those 2 extra pills for the next malaria incidents. They will use the whole dose. So train, make sure the information flows down, but also make sure that the information flows back up so that they understand what the challenges are for the frontline workers. Thank you.
Thank you very much. Before I leave, I want to say one thing, and I can't go without saying it. I look at, I don't like vertical programs, true. But I look at the polio eradication program, polio eradication initiative that I've worked on. I chair the African Regional Certification Commission. And I see how that has functioned with, WHO, UNICEF, Rotary, CDC, Bill and Melinda Gates Foundation, and now Gavi, how they all come together. And each one, you go to a country, if you say vaccines, UNICEF says yes. If you say technical services or what, WHO is there. If you say what, so they are involved in each country. Talking of data, this is what got me. You can sit in Brazzaville and know what's happening in Nigeria. You can see, because data is all together, there's somebody taking care of that. We need a real paradigm shift if we talk about eradication. I'm not talking about, just one vertical program, but to think of a real shift. How can we accelerate progress? We'll come back next year again. We might be saying the same things. Yes, we had a few, this has happened, it's gone down a little bit. But we need to really think. Polio has a legacy, and I really think we need to take not all of it, but there are some parts of it that we really need to take and have as best practices. And then you go in a country and you see a donor in the entire country, not just in one little section. What will happen to the other parts of the country? What will happen to the other countries where the donors are not there? We have to think about all of this so we all move together. And with that, I just want to say thanks to you all for this. We're sorry, it started really quite late. We can't have a good discussion here. But we can continue the discussion as we go out. Thank you very much.
Thank you.
Another round of applause to our co-chairs and our esteemed speakers. You may stay for a picture, please. Thank you so much for reminding us that although we have to celebrate progress, but also there is a clear need to address the stagnation of progress in malaria burden reduction observed in Africa. Thank you so much. Another round of applause to the speakers. At this time, thank you so much. Thank you. At this time, we are going to welcome our guest of honor as he will be delivering his remarks for today. After that, we will give time to the first row of our guests to have a group photo on stage as we get ready to move to the room where we will have our welcome dinner, our dinner to celebrate the World Malaria Day. Welcome to the Permanent Secretary at the Ministry of Health. Thank you.
Distinguished guests, ladies and gentlemen, good afternoon. Bonsoir. It's a great honor for me to address you today as we celebrate the World Malaria Day for 2024, which is coinciding with the 8th Pan-African Conference on Malaria. This year's global theme, which talks about accelerating the fight against malaria for a more equitable world, is a reminder to all of us of the profound impact that malaria continues to have on our lives, of which, like everyone who spoke before talked about it, 95% of the global burden falls on our lovely continent, Africa. The convergence of the two events today underscores the significance of our collective efforts and commitment to advancing the fight against malaria at both national, regional, and global scales. Our national theme for this year in Rwanda, which has been there for the last 4 years, is Zero Malaria Start With Me. It actually starts with me. It underscores the principles of individual responsibility and collective actions in our efforts to eliminate malaria. It speaks to the importance of empowering every citizen. We spoke about the role that community health workers are having in the control of malaria, treating actually 60% of the malaria cases here in Rwanda. We did not speak about the role they are having probably in the prevention. If they are not playing their right role, would be having more than the cases we are having today. Community mobilization, advocacy, policy development, and healthcare delivery is played by every person, from the community health workers, from the ordinary citizens, policymakers, political leaders, as well as ordinary citizens. As we gather here today, we must recognize fundamental principles of health equity, gender equality, and human rights as guiding principles in our fight against malaria. And I'm very sure that at least everyone here in this room knows very well the difference between equity and equality. I think the people who set this stage know the principle of equity. So when I came to the stage, I used the stairs. And I'm imagining if there was someone with a wheelchair who wanted to come to the stage. If it was a principle of equality and they are required to use the stairs, I know they wouldn't be reaching the stage, and equality would have failed. But because of equity, the people who set the stage thought of this lamp where the wheelchair person can pass. And I've also seen some people use this support to reach the mic. If it was about equality and this support was not there, I'm very sure they wouldn't have spoken on the mic. But because of equity, so we are all speaking on the same mic and delivering the message. That's how we should be working in the fight against malaria. Equity means giving everyone what they need to be treated, everyone what they need to be cured, and every country the resources required to treat their people. If you were to give, for example, a country like Uganda, where they spoke of millions of cases, equal resources like Cape Verde, that has 500,000 people. Actually, they have less people than our annual case of malaria. The program manager spoke about 600,000 cases in a year. Yet in Cape Verde, they only have 500 people. If it was about equality, I think some would be getting more than equal. So equality in our programs and in our response is very important, but equity matters a lot. Health equity demands that we address underlying social determinants of malaria by ensuring that access to prevention, diagnosis, and treatment services is available to all, regardless of their socioeconomic status or geographical location. Gender equality also requires that we recognize and address the unique vulnerability faced by women and girls about malaria, but also as well as their potentials as the agents of change that malaria control efforts, we can invest in them. As we all continue to reflect on the progress that we have made in our respective countries, as well as the remaining challenges that rise ahead, let us all echo the power of innovation. I've seen innovation there. I've seen integration there. Let us echo the power of innovation, collaboration, and solidarity to accelerate the progress, which can only help us to keep track toward the global technical strategy 2030, which targets to an African country free of malaria. As I conclude my remarks tonight, I extend my heartfelt gratitude to each of you for your strong dedication to combating malaria, and particularly for having joined us here in Rwanda at the occasion of the MIM conference, but also joining us this evening as we mark the World Malaria Day with us today. Let us all continue to work towards the future where malaria is no longer a threat to ourselves, our families, our communities, and our countries, but also our continent. As a key take-home for today, we should all remember that zero malaria starts with B. And the theme, which we have been using for 4 years, I have to tell you all, as you take it home, that it is always in direct form. Direct form to mean you can never use it in indirect form to say, for example, zero malaria starts with you. If you say zero malaria starts with you and point a finger to someone, here we say 4 fingers are looking at you. So zero malaria actually starts with me and starts with me as a whole. Thank you all for your kind attention and good evening.
Thank you so much to the Permanent Secretary. At this point, I'll kindly ask the first row to join the guest of honor at the stage for the group photo of today. I will ask others to remain seated as we wait for the group photo to be taken. The protocol team and the media team kindly help us to take this group photo. And after that, we'll be ushered through that door to the place where we'll have our World Malaria Day dinner. Yes.